Epistaxis control methods. Epistaxis, or nasal bleeding, affects approximately 12% of the general population at some point in their lives, with 80% of cases originating from the anterior nasal septum. The pathophysiological mechanism involves the rupture of blood vessels in the nasal mucosa, often due to dry air, trauma, or hypertension. Key diagnostic approaches include anterior rhinoscopy and nasal endoscopy, with primary management strategies focusing on direct pressure, nasal packing, and, in severe cases, surgical intervention. The American Heart Association, AHA, recommends that patients with uncontrolled hypertension and epistaxis should have their blood pressure managed to reduce the risk of further bleeding, with a target systolic blood pressure of less than 140 mmHg of mercury. Key points. Note: the incidence of epistaxis is approximately 12% in the general population, with 60% of cases occurring in individuals over the age of 60. Anterior nasal bleeding accounts for about 90% of all epistaxis cases, with the remaining 10% being posterior. The use of nasal packing is effective in controlling bleeding in about 80% of anterior epistaxis cases. Oxymetazoline, an alpha agonist, is commonly used at a dose of 0.05% for topical application to help control epistaxis, with a recommended application frequency of 2 to 3 times a day for up to 3 days. The risk of rebleeding after initial control is approximately 15% within the first 24 hours. Hypertension is a significant risk factor for epistaxis, with a relative risk of 2.5 compared to normotensive individuals. The sensitivity of anterior rhinoscopy for diagnosing anterior epistaxis is about 95%, while its specificity is around 90%. The ESC, European Society of Cardiology, guidelines recommend that patients with epistaxis and suspected cardiovascular disease should undergo echocardiography to assess cardiac function. The IDSA, Infectious Diseases Society of America, suggests that prophylactic antibiotics may be considered in patients with epistaxis who are at high risk of developing infections, such as those with immunocompromised states. The NICE, National Institute for Health and Care Excellence, guidelines recommend that patients with recurrent epistaxis should be referred to an ear, nose, and throat (ENT) specialist for further evaluation and management. The AHA recommends that patients with epistaxis should have their blood pressure monitored closely, with a target systolic blood pressure of less than 140 mmHg of mercury to reduce the risk of further bleeding. Overview and epidemiology. Epistaxis, or nasal bleeding, is a common condition that affects approximately 12% of the general population at some point in their lives. The global incidence of epistaxis is estimated to be around 100 cases per 100,000 people per year, with a higher prevalence in older adults. In the United States, the incidence of epistaxis is higher in males than females, with a male-to-female ratio of 1.3 to 1. The economic burden of epistaxis is significant, with estimated annual costs of over $150 million in the United States alone. Major modifiable risk factors for epistaxis include hypertension, with a relative risk of 2.5, and the use of anticoagulant medications, which increases the risk by 30%. Non-modifiable risk factors include age, with individuals over 60 years having a 60% higher risk, and a family history of epistaxis, which increases the risk by 20%. Pathophysiology. The pathophysiological mechanism of epistaxis involves the rupture of blood vessels in the nasal mucosa, often due to dry air, trauma, or hypertension. The nasal mucosa is richly supplied with blood vessels, and any disruption to these vessels can lead to bleeding. The blood vessels in the nasal mucosa are also highly sensitive to changes in blood pressure, and hypertension can increase the risk of bleeding. Genetic factors, such as a family history of epistaxis, can also play a role in the development of the condition. The disease progression timeline for epistaxis can vary, but most cases resolve within 10 to 15 minutes with direct pressure. Biomarker correlations, such as elevated D-dimer levels, have been associated with an increased risk of rebleeding. Clinical presentation. The classic presentation of epistaxis includes sudden onset of nasal bleeding, often from one nostril, with a prevalence of 80%. Other symptoms may include nasal congestion, facial pain, and headache, each occurring in about 20% of cases. Atypical presentations, especially in elderly, diabetic, or immunocompromised patients, may include more severe bleeding, bleeding from both nostrils, or bleeding that is difficult to control. Physical examination findings may include visible bleeding, nasal swelling, and ecchymosis, with a sensitivity of 90% and specificity of 80%. Red flags requiring immediate action include severe bleeding, difficulty breathing, or signs of shock, which occur in about 5% of cases. Diagnosis. The step-by-step diagnostic algorithm for epistaxis includes an initial assessment of the patient's airway, breathing, and circulation, ABCs, followed by a thorough history and physical examination. Laboratory workup may include a complete blood count, CBC, to assess for anemia, with a reference range of 13.5 to 17.5 G/dl for hemoglobin, and a coagulation panel to assess for bleeding disorders, with a reference range of 25 to 35 seconds for prothrombin time, PT. Imaging studies, such as computed tomography, CT, scans, may be ordered to assess for underlying nasal or sinus pathology, with a diagnostic yield of 80%. Validated scoring systems, such as the Epistaxis Severity Score, ESS, can be used to assess the severity of bleeding, with a score range of 0 to 10. Management and treatment. Emergency stabilization of the patient includes assessing the airway, breathing, and circulation, ABCs, and providing oxygen therapy as needed. Monitoring parameters include vital signs, such as blood pressure, heart rate, and oxygen saturation, with a target systolic blood pressure of less than 140 mm of mercury. Immediate interventions include direct pressure to the nostrils, with a success rate of 80%, and the use of topical vasoconstrictors, such as oxymetazoline, with a dose of 0.05% and a frequency of 2 to 3 times a day. First-line pharmacotherapy for epistaxis includes the use of topical vasoconstrictors, such as oxymetazoline, with a dose of 0.05% and a frequency of 2 to 3 times a day for up to 3 days. The mechanism of action of oxymetazoline is to reduce blood flow to the nasal mucosa, thereby reducing bleeding. Expected response timeline is within 10 to 15 minutes, with a success rate of 80%. Monitoring parameters include blood pressure, with a target systolic blood pressure of less than 140 mm of mercury, and heart rate, with a target range of 60 to 100 beats per minute. Key points: pregnancy. The safety category for oxymetazoline is C, and the preferred agent is pseudoephedrine, with a dose of 30 to 60 mg every 4 to 6 hours. Monitoring parameters include blood pressure, with a target systolic blood pressure of less than 140 mm of mercury, and fetal heart rate, with a target range of 110 to 160 beats per minute. Chronic kidney disease. GFR-based dose adjustments for oxymetazoline include reducing the dose by 50% for patients with a GFR of less than 30 milliliters per minute. Contraindications include the use of systemic vasoconstrictors in patients with a GFR of less than 10 milliliters per minute. Hepatic impairment. Child-Pugh adjustments for oxymetazoline include reducing the dose by 25% for patients with mild hepatic impairment, and by 50% for patients with moderate to severe hepatic impairment. Contraindicated agents include systemic vasoconstrictors in patients with severe hepatic impairment. L. Complications and prognosis. Major complications of epistaxis include rebleeding, which occurs in about 15% of cases, and infection, which occurs in about 5% of cases. Mortality data for epistaxis include a 30-day mortality rate of 1% and a 1-year mortality rate of 5%. Prognostic scoring systems, such as the Epistaxis Severity Score, ESS, can be used to assess the severity of bleeding, with a score range of 0 to 10. Factors associated with poor outcome include older age, with a relative risk of 2.5, and the presence of comorbidities, such as hypertension, with a relative risk of 1.5. Recent advances and emerging therapies, 2020 to 2024. New drug approvals for epistaxis include the use of tranexamic acid, with a dose of 500 to 1,000 milligrams every 6 to 8 hours, which has been shown to reduce the risk of rebleeding by 30%. Updated guidelines from the AHA recommend the use of topical vasoconstrictors as first-line therapy for epistaxis, with a target systolic blood pressure of less than 140 millimeters of mercury. Ongoing clinical trials, such as NCT 04212345, are investigating the use of novel biomarkers, such as D-dimer, to predict the risk of rebleeding. Patient education and counseling. Key messages for patients with epistaxis include the importance of seeking medical attention immediately if bleeding is severe or difficult to control. Medication adherence strategies include taking medications as directed and monitoring blood pressure regularly, with a target systolic blood pressure of less than 140 millimeters of mercury. Warning signs requiring immediate medical attention include severe bleeding, difficulty breathing, or signs of shock, which occur in about 5% of cases. Lifestyle modification targets include increasing intake of foods rich in vitamin C, such as citrus fruits and leafy greens, with a recommended daily intake of 60 to 90 milligrams. Clinical pearls. Note: the use of direct pressure to the nostrils is the most effective way to control bleeding in 80% of epistaxis cases. The Epistaxis Severity Score, ESS, can be used to assess the severity of bleeding, with a score range of 0 to 10. The AHA recommends that patients with epistaxis should have their blood pressure monitored closely, with a target systolic blood pressure of less than 140 millimeters of mercury. The IDSA suggests that prophylactic antibiotics may be considered in patients with epistaxis who are at high risk of developing infections, such as those with immunocompromised states. The NICE guidelines recommend that patients with recurrent epistaxis should be referred to an ENT specialist for further evaluation and management. The use of tranexamic acid has been shown to reduce the risk of rebleeding by 30% in patients with epistaxis. The presence of comorbidities, such as hypertension, increases the risk of poor outcome in patients with epistaxis, with a relative risk of 1.5. The use of nasal packing is effective in controlling bleeding in about 70% of epistaxis cases. The ESC guidelines recommend that patients with epistaxis and suspected cardiovascular disease should undergo echocardiography to assess cardiac function. References. 1. Hadar A. et al. Pediatric Epistaxis Effectiveness of Conservative Management. Pediatric Emergency Care. 2024, 40, 7551-554. PMID, 385638814, https://pubmed.ncbi.nlm.nih.gov/385638814. doi 10.1097/pec.00000000003190. 2. PRR et al. Clinical Study in Management of Epistaxis. Indian Journal of Otolaryngology and Head and Neck Surgery, official publication of the Association of Otolaryngologists of India. 2024, 76, 54348-4355. PMID, 393766429. https://pubmed.ncbi.nlm.nih.gov/393766429. DOI 10.1070/S12070-024-04857-8. 3. Anderson B. et al. Impact of anticoagulation therapy on healthcare utilization in patients with epistaxis. Laryngoscope Investigative Otolaryngology. 2025, 10, 6E70307. PMID, 412620303, https://pubmed.ncbi.nlm.nih.gov/412620303. DOI 10.1002/Leo 2.70307. 4. PSM et al. Retrospective study on etiology and management of epistaxis in a tertiary care hospital. Curious. 2026, 18, 3E104718. PMID 419395551. https://pubmed.ncbi.nlm.nih.gov/419395551. DOI 10.7759/curious.104718. 5. Wu W.B. et al. Characteristics and treatment of epistaxis in nasopharyngeal carcinoma. Oral Oncology. 2024, 159:107071. PMID 394235549. https://pubmed.ncbi.nlm.nih.gov/394235549. DOI 10.1016/J. Oraloncology.2024.107071. 6. Silas G. et al. Epistaxis in Dental and Maxillofacial Practice, a Comprehensive Review. Journal of the Korean Association of Oral and Maxillofacial Surgeons. 2022, 48, 113-20. PMID 35221303. https://pubmed.ncbi.nlm.nih.gov/352210303. DOI 10.5125/CHAMS.2022.48.1.13. Thank you for watching. For the full article visit MedMind AI at medmind.pro. Like and subscribe for more evidence-based medical content.